Good morning, everybody. Just letting you know, in case you don't, there's breakfast tacos available along with drinks, such as coffee and water. I don't know if there's soft drinks, but there is water. Happy Father's Day to those that are fathers, and those that are not, make sure you call your father or father figure. Our first speaker of the morning is going to be Dr. Eisen. Dr. Eisen and his wife, a pediatrician and Valley native, relocated to Harlingen upon completion of their medical training. A former baseball player, Dr. Eisen ultimately hung up the cleats for a career in athletic training. He received a bachelor's degree in athletic training at Troy State University, working under esteemed orthopedic surgeon Dr. James Andrews. While completing a master's at Louisiana State University, he took part in one of Skip Bertman's national championship baseball teams. Dr. Eisen served a short stint with the Tampa Bay Rays organization as a minor league athletic trainer before attending medical school. During his sports medicine fellowship, he covered collegiate and professional organizations, including Seton Hall University and the New York Jets. Currently practicing in Harlingen, Texas, he sees patients across a wide spectrum of injuries. Dr. Eisen has worked extensively with the Special Olympics and enjoys educating students and residents on the evolving field of sports medicine. Ladies and gentlemen, Dr. Eisen.
Thank you for the introduction. Everybody hear me okay? Good, good. Good morning, everybody. As we've known, this is SPAT's closing day, the getaway day. Hopefully for some of you, you're staying a little bit longer. I'm Michael Eisen. I'm here to talk about a subject which is very near and dear to me. I grew up in Florida playing baseball. I still enjoy seeing some of my favorite athletes to examine are the overhead throwing athletes. And to say this is my term, this disabled throwing shoulder, that's not accurate. This is actually a term that was used by Stephen Burkhardt up the road in San Antonio. Him and two other orthopedic surgeons, Morgan and Kibler, the so-called orthopedic three amigos, came up with this term back in the early 2000s. And they published 3 papers, which still are very relevant today, even though they're approximately 15 years old. And they covered this topic called the disabled throwing shoulder. We're going to see a couple of those items from their articles down the road a little bit. Of course, Greg Maddox in any uniform, he was the antithesis of the disabled throwing shoulder with his form. And we're going to go through what makes a successful intervention as far as biomechanics a little bit down the road. In terms of conflicts, no conflicts. I would like to disclose, though, I used to be more of an ardent baseball fan until I watched the Roger Clemens testimony. The steroid talk really, or the testimony to Congress really threw it off for me, so I see the game a little bit more tainted today. So that could be seen as a conflict. Again, thank you to SPATS for having me speak on this topic. And of course, as we mentioned, happy Father's Day. So our objectives. Upon completion of this presentation, we should be able to understand what we're up against in terms of the risk and the extent of upper extremity pathology. And we're not going to dig deep into the pathology. We're just going to take it from a glancing blow, so to speak. We're going to discuss biomechanics of the overhead throwing athlete, the work of Atwater and Glenn Fleissig at ASMI. I mean, these are people who have really dedicated time, research, and they know this on a whole different level than I do, greater than I ever will. But I think we should have a basic understanding of the biomechanics of our throwing athletes. We should be able to competently assess our throwing athlete style in this day and era of iPads, iPhones, things that we can put our players and athletes on slow motion and we can watch it. For example, when I see people for concussions, most of the time they'll come to me and say, well, here's a picture of the hit. And everything is recorded these days, so we should be doing the same. We will understand why the disabled throwing shoulder accolade is very appropriate for the athlete. We'll talk about briefly, and this kind of hits to the point of it, why is it difficult to treat these athletes and why we should focus more on prevention. We'll talk about risk factors that the overhead throwing athlete has, whether that be at the beginning of the season or during the course of a season. We'll review a couple studies. There's many out there. I picked 2 or 3 from the high school scenario for which strength and conditioning does play a role and is shown to help in terms of overhead throwing athletes. And lastly, we'll implement, or my choice of an overhead throwing athlete program. So our job in the healthcare field obviously is prevention. And this is something I see on a daily basis with these throwers. I apologize, I didn't grab x-rays from the office for the first one, but this one is the classic Little League shoulder, and you see the widening of the growth plate on the outside as the first manifestation. It can progress. I've seen a couple of these in young girls, softball players, 10 years of age, where you get this widening on both sides of the growth plate with demineralization. I've never seen a stage 3 yet where they actually have that slipped epiphysis, but I'm sure they're coming, and we'll talk about why that is in a moment. The x-rays on the bottom, this comes from a local high school where 2 of their pitchers I saw recently, both with elbow problems. And you can see here, this growth plate on the medial epicondyle is definitely involved. We did an MRI, that's an acute stress fracture, and he received a compression screw. When I saw this athlete, and I ask every overhead throwing athlete, what exercises do you do? And their first, I mean, they blurt out almost instantly, bench press, squat, and somewhere around the way they'll say something about a lunge. And I'll ask them, well, what about this? What about, and it's not there. So I think we really need to focus more on prevention to keep them out of this so-called boneyard here. So going through our set of objectives, first we'll touch on this, what we're up against and the pathologies. Back at Troy, my mentor, Chuck Ash, used to say all coaches were former players. So from a former player's perspective, i.e. the coaches, this is an article taking us through whether or not coaches are aware of the compliance of pitching rules that have been outlined by USA Baseball. And just to go real quick to the summary of this article, what they said is most coaches are not aware of the information put forth by USA Pitching, and the recommendations of their knowledge is poor. The little graph on the side there, which you see, this area in the gray, this is the coaches at various levels, 9, 10, 11, 12, 13, 14, and this is their thoughts thinking they're in line with the recommendations. The one in the black is they think what their other coaches are doing wrong. So you can see here, they think they're doing everything right while the other team's coaches are doing everything wrong. It's a bit of introspection on the coach's brain. Enough about the coaches, let's talk about players. This was a recent journal article from 2015 asking players up to the age of 18 about injury prevention. And I just took 2 of the graphs from that article. One was, have you heard of USA Medical and Safety, the pitching guidelines? And overwhelming 8 to 9 out of 10 said no. What body part are you most likely to injure when it comes to baseball? The #1 area, ankle. Almost half the people said ankle. Almost a third said elbow. And since this was done in 2015, I think we're seeing a bit of this overrun from the Tommy John epidemic that we're seeing, so that it's on the radar. But nowhere mentioned is the shoulder. Just in terms of risk, the shoulder and elbow are the most commonly injured areas in the overhead throwing athlete due to this attrition or this repetitive microtrauma. As I alluded to in the prior slide, there's an epidemic, as we're very well aware, of Tommy John procedures. There was a stat in 2014, more ulnar collateral ligament reconstructions were done in the major leagues than all of the 1990s. So that puts it in perspective. Less than 1% of all baseball players participate in the collegiate or professional ranks. So that means 99% of the population falls underneath our watch. 99% of these athletes don't have a pitching coach. They don't have someone to cue them up and go through what is going on with their windup. So really, again, it falls on us. And we see here just on the graph of, this is Tommy John and Dr. Frank Jobe, one of the few physicians in the Major League Baseball Hall of Fame for what he did for the sport. And you can see on the rise, so the ulnar collateral ligament reconstructions. In terms of data on injuries, this was a study from 2012, and they took 6 years of Major League Baseball, and they looked at all the injuries from within. And over a period from 2005 to 2008, there was almost a 40% increase in injuries. Not surprisingly, April, most commonly associated with the most injuries, beginning of the season. The end of the season is September, the least amount of injuries. And if we look at that data, I think maybe it's because most of the people might already be on the disabled list. However, the takeaway was pitchers are third. They have 33%, practically a higher incidence of injuries versus position players. Here's just the graph showing us from 2005 to 2008, the red one being pitchers, blue is all players, position players on the bottom. And focusing on the other graph here, or the picture rather, pitchers only, you can see are overwhelmingly upper extremity, even though this includes the entirety of the arm, but it's going to be upper extremity. And looking at the top, all players, AL, NL, 50% are involved in the upper extremity. Big graph, a lot of numbers. Again, the takeaway, if you look at pitchers at the top here, overwhelmingly elbow, shoulder, elbow, 1, 2. Those are the takeaways. And so their conclusion was, for Major League Baseball, we need to look at the effectiveness of off-season and preseason training and in-season conditioning programs. We should look at them more closely so we can implement an evidence-based approach. And that's in Major League Baseball. These are people who already have, I'm sure they have programs going right and left, as I've already, I was involved in it, and these guys are doing programs daily. So just in high school, you're going to miss some games. That's unfortunate. College, on a higher level. And at LSU, we lost a guy in super regionals, which really affected our team. Fortunately, we were able to capitalize still. But looking at the front office vantage point in Major League Baseball, you look at our friend from the Arizona Diamondbacks here. He makes $35 million a year. Based on his stats last year, that's about $1 million a game, $300,000 an hour. He threw almost 3,300 pitches last year, so that equates to $10,000 a pitch. And if he walks somebody intentionally, that's 40 grand in the pocket. So from the front office perspective, injuries are a big deal. Let's talk a little bit about biomechanics for a moment. And again, I'm not going to go into a breakdown level, but I think we should look at it from at least a good perspective. It takes about 1 second to complete the baseball motion. It used to be 4 phases, but later on got to change to 6 phases, and each one is named for its major contribution to the throwing motion. Biomechanics are reasonably consistent from one pitcher to another. In my youth, I remember watching pitchers like Kenta Colby, Dan Quisenberry, Gene Garber. There was a guy named Rocker from the Braves, and these guys were side armors. They were submariners, and studies have shown these people put additional stress on the elbow as well as the shoulder, so their biomechanics are a little bit different. At the bottom of the screen, we look at the six phases, starting with windup, early to late cocking, acceleration, deceleration, and follow-through. And we're going to talk about the biomechanics associated with each of these phases. Before we do that, let's just talk a little bit about the language related to the throwing motion. And we always start with what we call the kinetic chain. And this is basically the inference of generating force from the lower extremities all the way through the funnel, the scapula, through the shoulder to the release of the hand. The whole point being this is optimal coordination, multiple segments to disseminate forces, and that's the key. You want to disseminate the forces, and that leads to the efficiency of the task. When they release the ball, we know there's 4 areas of the body which contribute to the velocity. It's the trunk rotation, shoulder internal rotation, elbow extension, and wrist flexion. Studies have shown up to 50% of your force generated comes from the lower extremities in the throwing motion. Much like there is many of these arrows pointing in all different directions, when you have a chain, there are multiple points of breakdown due to various reasons. It could be endurance-related, flexibility, or strength. Deficits lead to problems down the road, and they can lead to injuries and performance. And there's often something called a catch-up phenomenon, where these breaks in the kinetic chain, they alter forces in distal segments, and that leads to the injuries or performance concerns. Busy slide. I'm gonna try to break this down a little bit more. So there's this principle called the summation of speed phenomenon, and what we're talking about here is this kinetic energy is derived from each rotation of the body segment. It's conserved and then transferred to the most distal segment, the so-called proximal to distal sequencing. And the summary of this is ineffective timing. You get higher joint kinetics. To compensate for these higher joint kinetics, you have to generate. Pardon me, let me back up. To generate these higher joint kinetics, you have to compensate for loss of momentum to maintain ball speed. So for example, if you had an issue related to your elbow above here, then all of these sequences down below within the throwing motion are going to be offset. And just one more on the linguistics of throwing and the so-called thrower's paradox. And this comes from Kevin Welk and James Andrews. This was in 2002. And what they said here is to maximize force this elastic energy that can be transferred to the ball, structures must strike what we have a delicate balance. And this delicate balance is this adequate laxity to achieve this full range of motion, this maximal external rotation, with sufficient stability to inhibit subluxation. So if you look at the picture here, you and I, we get about 90 degrees of external rotation. The average major leaguer has about 165. And you think about that anterior, the force on the humeral head and how it has to remain within the joint, it's unbelievable. Let's just talk about the delivery style. So there's this nodes, as they're called, and what they are these progressive motions described to achieve the overhead throwing motion efficiently. Nodes, they decrease the freedom, so they decrease freedom in the kinetic chain to achieve maximal torque with minimal force development. And you see here 50 Cent, right? He has one of the most infamous first pitches in Major League Baseball history, but give him a break. He's been shot over 50 times, so his nodes are going to be lacking. This is Ben Kibler's paper recently in 2016, which goes over these nodes. It's a good review. 8 nodes. We'll talk about them in a pictorial form in just one moment. This was a paper out of the Curlin Job Clinic looking at youth pitchers, and we're going to take some of the images right now. So when we're looking through the iPad, when we're looking through the iPhone, whatever recording device, this is what you want to see in your kids. A is correct, B is incorrect. So when they're entering early cocking, you want to make sure they have their pelvis leaning toward the plate. You don't want them upright and already entering early cocking because that's generating too much force on the throwing arm. Looking at the next picture beside, throwing hand on top, you never want to see them throwing the ball with their forearm or the ball in supination. That is incorrect. The elbow should always be at maximum height before or right at stride foot contact. The picture on the other side shows 2 examples. There's the closed shoulder towards home plate, and also you see the foot down below, which is in line with home plate. So if you think about throwing across your body, if the foot opens up, all your force is being taken away. That's a waste of momentum and also a strain on the shoulder. And same if you close your foot in the opposite direction, that's a lot of force upon the shoulder. Looking at this long term at the bottom here, all we're saying is that they're achieving maximal external rotation as the arm is coming through. And lastly, you always want the hips facing home plate rather. I'm not going to go through all these pictures, but this is an excellent article again by Glenn Fleissig, very accessible online, Sports Health. And what he does is just goes through the pitching, the wind up through the deceleration, tells you what to look for, and tells you what happens when it's not present. And it's a great review. And just to wind up biomechanics, this was a study from the Journal of Shoulder and Elbow Surgery, and they looked at relationships between ball velocity and throwing mechanics in collegiate baseball players. This graph or table on the right shows you 9 kinetic variables that they looked at that have been well studied and documented via the pitching motions, and they found 3 of them that made the difference between a pitcher who throws with a significant amount of velocity and someone who does not. And the 3 are if they have maximum shoulder external rotation in that late cocking phase, knee flexion at release. Glenn Fleissig said that you should have extension when the pitcher releases the ball. If you watch them from the side, they should have about 80% of their body height as far as if they cut their extension short and their flex, you're taking away speed. So knee flexion at release, and of course trunk tilt at release. The more trunk tilt you have when you're throwing the ball, the longer you hold on to it, the more velocity you're going to generate. So why is this disabled throwing shoulder a setup? For the simple fact that it's one of the fastest human motions that can be recorded or ever recorded. When Glenn Fleissig initially studied this motion, he put up the camera and he realized when he watched the footage, he was missing so many frames. And the reason for that is because shoulder internal rotation happens at about 7,000 degrees per second. In regards to forces that the shoulder generates, late cocking, when you get back in maximum external rotation, there's about 1 time the body weight generated on the anterior portion of the shoulder. When you hit follow through, the posterior cuff, the capsule, they hit about 1 to 1.5 times of body weight loading through, as you can see on this picture And there's been numerous studies in regards to the ulnar collateral ligament, which cite the ulnar collateral ligament has a breaking point of approximately, they say, 32 newtons. The pitching motion delivers 35 newtons of force. So it's up to these other structures in the shoulder of the arm, and you must do this motion correctly in order to sustain a viable ulnar collateral ligament. Another big chart, but it goes back to those early x-rays I showed you. And it just talks about biomechanics of forces. In this study, they looked at youth, high school, collegiate, and professional. Plain and simple. And at the bottom where I've started, what you see here is it doesn't matter in youth, high school, whatever the setting, they have pretty much equal forces throughout. You can see even youth athletes are hitting 7,000 degrees per second in shoulder internal rotation. So that's why we're seeing the pathology that we're seeing. That's why we're seeing these growth plates become affected with these young kids. And that's why they're going to benefit from what we're going to talk about today. So just to summarize the biomechanic portion, take time to observe them. I know we're busy. Time is precious for us. Just covering a minor league baseball team was enough. I can't imagine caring for an entire high school. That's got to be just, you have no time. But I think the time that you invest to watch these athletes is going to help you down the road in terms of preventing injuries, and that's going to be time taken away from you later on in the training room to take care of them. So what makes it difficult? And again, I'm not here to talk about evaluation of the throwing shoulder. Just this throwing shoulder is inherently difficult to evaluate. The structures are deep. They're not always, you can't always say, I've palpated the structure. You have multiple examination procedures for the same structure. You could have multiple tests that are positive because there's so much overlap with structures. Pain patterns are obviously, they're not specific. And you also get the occasional zebra. I saw someone on Thursday who had, they started with a cervical MRI. 2 days later, had an MRI of the left shoulder, and I knew I was in for something with that patient, and I think they had thoracic outlet. We're working them up currently. In terms, just on a side, in terms of evidence-based shoulder evaluations, this was a paper by John Kane. He's a sports medicine doc out of University of Washington. And it's an excellent, I mean, he summarizes, there's 30 different examination maneuvers for the shoulder, and he takes it and says, here's 9, 10, run with it. And he has a good summary. Just one other thing, when examining the patient, and this comes from Kibler and Burkhart Morgan's work, this is the second journal article of their series, and they talk about something called the 6 syndrome with the scapula. If you're not evaluating your shoulders from the back, you're missing the whole point. And I remember reading this article, and I saw this picture on this side, and I said, holy cow, I know this guy just from the hair alone, right? And it said in the caption, this World Series pitcher for the Boston Red Sox, and it's Curt Schilling. And you can see here, I drew the line because you really couldn't see so much of the tilt without it, but left shoulder greater than a right, he's a right-hander. And what did they do? They instituted 6 weeks of periscapular strengthening, and lo and behold, everything lined up. So you have to take a look at your athletes, front, back. I usually have them hands by the side, hands on the hips, and have them do some repeated motions, forward plane and abduction. Patients come to see me. We have x-ray in office. We've got ultrasound. Parents want imaging, of course. The athlete thinks he needs imaging because the parents want imaging. So let's talk about imaging. And this was a study done in the St. Louis Cardinal organization, and they just did x-rays of the throwing of the dominant shoulder and elbow. And what they found was, of course, degenerative changes in the AC joint and the elbow. And the finding of the article was it still didn't correlate with time spent on the disabled list. It's just findings you're going to see with people who do what they do. Looking at MRIs, this was a 5-year follow-up, and they took 20 professional baseball players, and they did MRIs on the dominant and non-dominant shoulders. And what they found was 40% had partial or full thickness tears in the rotator cuff, 25% had Bennett's lesions. None of these people over the 5-year follow-up required any intervention. It's just findings we know are there. This was a 2016 study from February, recent study, and they took major league draft picks with asymptomatic shoulders, did MRIs on them, and what did they find? 17-year-olds, so a young kid already with a low-grade articular surface supraspinatus tear. This was a 19-year-old with already changes in the posterior labrum, so we know it's going to be there. And I always look for Dr. Andrews to make sense of these things, and what would he say? He would say, if you want an excuse to operate on a pitcher's throwing shoulder, just get an MRI. And he's absolutely right. So let's look at surgery for something as common as a slap repair. Slap repair is very common, 10% of all shoulder surgery, second most common arthroscopic procedure. And this was a 2014 study out of Houston, I think Methodist. And they looked at professional baseball players, and they looked at position players and pitchers. And this is the outcome, and I'll focus on just this side alone. So people entered non-surgical treatment, 40% returned to play. 22% returned to their previous level of competition. Okay, so we have surgical treatment of the non-surgical failures. Almost half returned to play, while only 7% returned to their previous level. So overall, surgery for slap repair, 62% returned to play, while almost a quarter only returned to play after treatment. So again, it doesn't guarantee you that you're going to get back to your previous level post surgery. And once again, what would Dr. Andrews say? He would say our advice to baseball players is to avoid surgery on the throwing shoulder if all possible. So let's talk about risk factors for these athletes. We know the biomechanics, we've talked about the forces. Let's talk about other risk factors we can perform and observe in the office. This was a Major League Baseball study over a 5-year period, and they did preseason shoulder strength training. And what they found was there was statistically significant association observed with prone external rotation, seated external rotation, supraspinatus strength in regards to a throwing-related injury requiring surgical intervention. And as well, they found supraspinatus strength significantly associated with an incidence of any shoulder injury. So right off the bat, that's a focus for our pitchers. Continuing on, so we know the season is a season of attrition, 16 pitchers, 16 position players, and they looked at glenohumeral posterior tightness and scapular position. In regards to position players, there was no changes at the end of the season. Pitchers, they had less scapular rotation, which led them to injury. And again, the conclusion was pitchers may benefit from these initiatives, which we're going to talk about. A couple of high school studies. Again, looking at almost 100 pitchers and 28 upper extremity injuries with a trend for supraspinatus weakness for an increased shoulder injury. And the conclusion, again, looking at major injuries, these are injuries which cause greater than 3 games missed. Preseason supraspinatus weakness was significant. Going over the strength and conditioning programs, I have 2 from the Andrews camp. One is a 4-week, one is a 6-week, and this was a 4-week program, control group, and the training group. And all they did was use some tubing exercises, a throwing program, and stretching 3 days a week for 4 weeks. And at the bottom, what you see here is a statistically significant amount of post-test gain in velocity. And while the training, or the control group rather, did not show any improvement, and that's not expected. Looking at the 6-week trial, they took 68 players, again, 14, 17 young people. They put them in 3 different forms of a strengthening group. That could have been throwers 10 group. They used these pneumatic machine exercises. They also used a plyometric program. And what they found was there was almost a 2% increase in throwing velocity, whichever strengthening program you utilized for the upper extremity. And lastly, there was one more where all they did was this simple, what they called a posterior shoulder endurance test, where they just had the athlete take the arm out to the side and they measured how many times they could do that. And they put them through a program for 20 weeks, and the findings were not only did they maintain their flexibility, but they also gained strength and endurance. So lastly, let's just talk about implementation of a program. And yours truly on the baseball card back in the days, this was 1998, I think, and here's my buddy Doug Jarrow, who's with the Cubs. What will we say? I always suggest the advanced throwers 10 program. And the reason behind this, there's so much evidence behind it. And the irony is these 2 exercises aren't from it at all. I always like the push-ups with the plus, the diagonal D1, D2. These are from this article, again, from Andrews, where they looked at EMG of the muscles performed during the exercises. And so this is where they get their evidence for. Big pattern saying, guess what? The evidence behind the thrower's 10, it works. And certainly it does. This is just the outline of the program. And it can be implemented with simple physio ball. It can be implemented with a little tubing, some light weights. You're done. That's it. It doesn't take machines, none of the above. These are some of the exercises. And here we see Kevin Wilk assisting here with a little bit of overpressure and perhaps making things a little more difficult for this athlete. This gentleman here doing the abduction. And actually, when I read the article back in the days, this was the Devil Rays 98 #1 draft pick, Jason Stanridge. And the point about this is not that I know him, but the fact that this guy is 6'6", he weighs 240 pounds, and he's using these powder blue weights. And that's what we really need to focus on supervision. And I'll get to the supervision in just one moment, because in the intro, when I asked the kid, okay, what exercises are you doing? I'm doing squat, I'm doing bench press. And 9 out of 10 times when I have kids come in the office, they'll say, well, demonstrate a squat for me. And their form is horrendous. It's absolutely horrendous. They're doing more damage than good. I think we owe them a bit of supervision to make sure they're doing this correctly, okay? Because what people want to do, of course, is add more weight, which is not the point. When you add more weight, what do? You bring in other structures to perform the weight, and that throws the EMG studies out the window. So our point is we got to watch these guys and gals do the exercise. We see external rotation in a side plank. You see this gentleman keeping the arm in a stable position while exercising the other one. And what we would do, and I know, again, time isn't an issue. Time is certainly an issue. When I was with Tampa Bay, what we would do is have them do their program, then we would meet with them one-on-one, and we'd take them through it manually. So we'd have them do prone exercises manually. We'd have them do the D1, D2 supine, and we test their strength just to make sure they're in check. And for me, that's what it's about. It's that interaction with the athlete. I don't think it's about just saying, here's a recipe, follow it. You know, it's that interaction with the athlete. They're making sure we're checking in on them, and we are, and they're aware of that. We had all the layouts at LSU and in Tampa. You know, we had all the exercises listed on the wall. This is the day of media. What you can do is tell them to go to YouTube. That's simple. The article's pretty dry, but if you go to YouTube, there's a 7-minute link. And it shows them how to do all these exercises, and it's done. And I recommend it to all the athletes. The 2 that I've seen in the office, that's what it's about. It's not about squatting and bench pressing and things that are going to ultimately not help you. It's about putting them on a better platform to perform. Of course, you know, you don't want to keep them just doing one set of exercises. That gets to be a bit mundane. You know, variety, you want to mix it up for them. Some additional resources that I like. This was the update paper on the Burkhart trilogy. This was the 10-year update, which came out about 2-3 years ago. And at the end of this paper, they have just a slew of exercises for the overhead throwing athlete, featuring the core, and it's a great read. And then Kevin Wilk, he also has another update. I think this was 2014. And again, has a great series of articles or a great series of exercises that can be added to and supplemented to that Advanced Throwers 10. Because they're, you know, athletes are going to lose their interest, and you got to keep them. You know, I'm not saying you have to do this every day. You don't have to do the whole thing every day, but you have to at least instill this at least 3 times a week, I would suggest. So in closing, we know it's a very high demanding task, this overhead throwing. You have to have proper mechanics to prevent injuries and to not impair their performance. The best time is to intervene early, and that's what I'm trying to do with these young kids with these horrendous x-rays. Baseball, people, you know, pick on it for being a sport of inactivity, but it's got some of the fastest motions ever recorded. Unfortunately, due to these forces and these rates of activity, and we see injuries happening young. The key is we got to development, it's prevention, overwhelmingly. If we're not doing that, we're doing them a disservice. And we know the reality is sadly that surgical intervention does not assure that ideal outcome. Oh, and that was if this is the heads up for concussion, this is the kin for baseball, pitch smart. And this has all the recommendations, and I tell parents, this is what your kids need to be doing. This is a link for them to understand, you know, what is the appropriate. approach to overhead throwing. And so I want to thank you for your time. And as a kid, I remember watching Nolan Ryan. He was one of my favorites. And there was this woman, I don't know, Morgana, the Kissing Bandit, if anybody remembers her. She used to run out in the field and surprise like the big players of the day. And Nolan Ryan was such a class act. He took a knee and gave her a hug, and I always remembered it as a kid. He's just a class act. And then here he is being a class act when Robin Ventura charged him out, someone he was double his age, and he got him in a headlock and punched him several times, and that was one of my favorite moments. So nonetheless, feel free to email me, michaelisisen@gmail.com. I'll respond as soon as I can. And thank you for your time and your attention. Thank you.
No, no, I think they're coming back in. put the bag down there, that way I don't forget it. Okay, all right. Thank you, man.
Okay, our next speaker is Alfred Castillo. He is the Assistant Athletics Director for Sports Medicine at Bowling Green University. He has held this position since 2014. Prior to Bowling Green, he served as the head athletic trainer at Southeast Missouri State from 2006 to 2014. Castillo is charged with overseeing Bowling Green Sports Medicine Department, as well as serving as the Director of Sports Performance within the Athletics Department. Prior to his time at Southeast Missouri State, Castillo was an assistant athletic trainer at Missouri from 2001 to 2006 and at Texas A&M from 1999 to 2001. Prior to that, he was the head athletic trainer at PSJ North from 1996 to 1999. He has served as a speaker at the Big 12 Conference Medical Aspects Meeting, the Mid-American Sports Medicine Conference Seminar, the Jesse Jackson Track and Field Clinic, and now at SPATS. Castillo earned a bachelor's degree in kinesiology from Texas Pan American in 1995 and a master's degree in sports physiology from Texas A&M in 2001. Ladies and gentlemen, Alfred Castillo.
Thank you, sir. Appreciate that. Is this mic on? Can you guys hear me in the back? Yes, excellent. Thank you, guys. Good morning. Happy Father's Day for those of you that are fortunate enough to have children. And my prayers go out to your wives as well. Happy Mother's Day in addition to that. It's always a challenge to have kids and raise them together. The Sunday crowd, I appreciate you guys being here. You guys are like the Sunday savages. You guys have gone through the workout Sunday morning. You're still here, and I appreciate you guys being here, okay? I don't have a slide for this, but I felt the need to throw out a disclaimer. I'm not getting any sponsorship dollars. I'm not getting paid in any amount by any vendor or anything like that. And the $50 that I won yesterday in the name drawing has nothing to do with anything other than me being here, so. All right. But anyway, Javier Manuel was giving me a hard time about that. Just so I can get started. This is kind of a quick resume, and all it is to represent where I've been at and along the way, the things that I've picked up. Okay. When I was at PSJ North, I was the only athletic trainer there, and I hear there's 3 there now, so I'm very envious of that situation. At Texas A&M, the situation there, we had chiropractic staff that would volunteer. We had a tremendous sports medicine group, excellent team position coverage, and that was a great situation. And we also had a rehab specialist, so any of the more in-depth care that was provided by the that needed attention post-op was handled by that individual. When I went to Missouri, we didn't have that option. We didn't utilize chiropractic care very much. We did have a tremendous sports medicine group, and we handled all of our rehab. So at that point, it became more and more of the individual staff to handle their own rehabilitations, acute or post-op, okay? At Southeast Missouri State, well, let me go back. At Missouri, I also became acquainted with a gentleman, massage therapist, great individual from San Diego, who helped us with our teams and had a very strong thumb. He swore that he could kill an individual with his thumb. So, and he taught me a lot. So I owe that individual quite a bit. Leaving Missouri to Southeast Missouri State, we were able to, I was in charge of the program. You're going to try and create something in the manner of which you want to operate it as. And tremendous, staff. Our team physician was actually a physiatrist. Okay, so that's uncommon to see within our sports medicine realm. And he's still a really good friend of mine, Dr. Jim Bowen. At Southeast Missouri State, we also implemented the FMS system. So I'll talk about that briefly as I get to it. And now at Bowling Green, I mean, I'm able to kind of sum up all the experiences that I've seen, the things that I've liked, a lot of the things that I feel could have been tuned up a little bit more. And I'm going to share that with you as I proceed through this. Background, I've been in sports medicine 20 plus years, a lot of football experience. I do have to backtrack. My whole goal getting out of undergrad was not to be a football guy. I wanted to be a basketball athletic trainer following my time at Pan American, because that's the team that I spent most of the time with. And it turns out I've not seen basketball since I've left Pan Am. So, and the 10 years as a lead person for a sports medicine program, 4 years of track and field experience, which may not be a favorite event or sport for most athletic trainers, but that is probably the one assignment that I benefited from the most. All the key injuries, wide variety of specialized events, throwers to distance runners to jumpers. So I tremendously benefited from that. I hit on the FMS work that we did at Southeast Missouri State. And our gentleman, Esteban Rubalcaba, was a dangerous thumb. He spent 2 years with me working with my massage therapy skills. And I've also worked directly with a sports psychologist who also happened to be our head track coach at Mizzou. I'm going to answer some of these. I don't know that I can hear most of your answers, but I'm assuming most of everybody in here is high school aged kids, right? You know, 15, 14 to 18, maybe 21 years old if the kid's been held back. I don't want to, you know, overstate that, but middle school kids, anybody? Middle? Anybody younger than that? No? Okay. Older than that? Collegiate athletic trainers in here? Yes. PTs? I know MDs are going to be scarce at this clinic. MD? PT. All right. Throughout the day, athletic trainers, I think we get to see our kids almost every day, 5 days a week. If it's more than that, raise your hand. Okay. Is it less than 5 days a week? Less than 5 days a week? So we have the advantage over any clinician to have more hands-on time with the individual patients. You know, we can see them maybe before classes start, maybe sometime in the middle of the day, maybe after school, before practice, and additionally, you know, if you have help or have hands post-practice as well. As far as the time that these individuals spend training, I'm assuming there's still at least a 2-hour limit, correct? Per day, per students, right? Unless you're playing football down here, it might go a little bit further than that, including conditioning time, right? Okay. A lot of this hopefully is review. These are not necessarily groundbreaking concepts, but they're things that I feel you need to reflect on, okay? I've probably worked with a dozen strength conditioning coaches, head strength conditioning coaches, and maybe several dozen assistant strength coaches at every institution that I've been at, beginning at the collegiate setting. And every single one of them agreed that at whatever age a student or a child starts participating in sports, it's okay to expect that individual child, male or female, to have at least a base level of strength, okay? If they start playing soccer, I mean, this is not just playing around or running around in the playground. This is engaging in, you know, soccer, engaging in a sport where they're going to be maybe colliding with another individual, maybe having to place their own force, their body weight against an individual. That's one of the arguments, or, you know, I guess dialogues that I've opened up with that. Upper body strength is important. Lower body strength is important. Anterior to posterior balance, you know, all that is indicating that they have a good posterior chain. Their glutes, their hamstrings are strong. Their low back is also strong, and there's not an imbalance front side to back side, okay? Core strength. Core strength is also something that has to be addressed as well. I've addressed this with my kids growing up as well, but I did not, don't assume I just put my daughter or my son underneath a barbell. No, they started off with body weight exercises, push-ups, sit-ups, single leg, sit to stand, bench squats, just to at least start a base before we moved on into more advanced maneuvers. The posterior chain, that shouldn't be a new term to anybody. The posterior chain is something that I heavily emphasize when I'm working with an athlete regarding a post-ACL reconstruction, any type of ACL or knee reconstruction. That's one of the things that we really hit on hard. And if you disagree with this concept, please raise your hand. Well, that's good, though. I'm glad we're all on the same page. And this goes on not just for kids that are participating in athletics. Bowling Green is up in Northwest Ohio. Okay, I've already been asked if it was in Kentucky. It's not in Kentucky. That's another school. This is in Ohio, northwest corner, just 20 minutes south of Toledo, about an hour south of Detroit. Our previous coach just left to go to Syracuse. Okay, got a better deal there. We did inherit one of our own from the state of Texas, Mike Jenks from Texas Tech. He's now the head coach at Bowling Green State. I can't say our coach's name, but you should be able to kind of Google who that is, and that was kind of his key words. Google it. You don't believe me? Google it. All right. So he's been gone, and he was a key individual that at his age, 50 plus years, was always hurt. I mean, he spent more time in the athletic training room than some of our athletes did. Shoulder issues, neck issues, back issues. And one of the key things that I was on him before he left, maybe a few months before I even knew he was going away, I had a heart-to-heart with him. I told him, Coach, you got to do something, man. You got to be consistent with your training. You got to work your posterior chain, your small muscle groups, your rotator cuff muscles, because he had shoulder issues from college. He played at Hawaii, low back issues from weightlifting training. And all sorts of problems, but he was not an individual that was going to take care of himself. So this has more applications than just athletics alone, more so than just, this is a long life-term event. You guys got to maintain a certain amount of strength just to live your life. And as active as athletic trainers are, I think it carries great benefit to continue with that. I don't have this on there, but neck strength is also something that I think needs to be addressed as well, especially in sports like middle school football, high school football, soccer, wrestling, anything where the head's going to be vulnerable and maybe receive an impact or blow. That also has to have at least a decent amount of attention towards strengthening. All right, this gentleman here in the picture kind of represents what my goal was to as far as attaining flexibility. I was a big Bruce Lee fan. Never could quite get to that limit on doing the split leg stretch, but it's something to aspire to, okay? For the flexibility and range of motion issues, we tend to try and get our student athletes at BG to get to 90 degrees. That's at least a fair level of measure for them to strive towards. Quad stretch test, which is the Ely's test, getting them on their stomach and bringing their heel to their butt. We want to try that to get the heel to the butt, make contact, or within 30 degrees. That's also going to give us another measure of flexibility, range of motion to shoot towards. I am actually surprised as to how many student athletes are not able to touch their toes, okay? At the level that we start working with athletes, either through a growth spurt or maybe not ever paying attention to flexibility work. This is something that they've neglected throughout their career or as an athlete. And ankle dorsiflexion, that's something that I think doesn't get enough attention. 20 degrees is something that we try to get our athletes to, and by minimizing or improving an athlete's ankle dorsiflexion or range of motion there, we've seen a lot of reduction in calf issues, hamstring issues, and in addition to that, it's also helped minimize a lot of our low back problems, okay? Are there any questions at this point with this concept here? Okay. Hamstring 90-90, that's pretty simple. This is one of the tests that we end up doing with our athletes, and they can be on their back. It's easiest to do on their back on a table that we have. We actually have a stretch table that we put our athletes on. lift their leg up as high as possible, past 90 degrees. It's important that they keep the leg locked. We don't do any type of stretch therapy with their leg locked until they've been used to this for a while. But for this measurement alone, we do expect the athlete to have the knee locked. And then we assess the ankle using a goniometer. The easiest thing is to kind of eyeball it. You can kind of tell that the model there in the picture is at about 90 degrees. And we measure both legs. Quad stretch test, just like I described, athletes on the table or on the floor, bend the leg. It's usually good to try and not crank on that ankle towards the buttocks area. Okay, we don't want anybody screaming or causing any quad strain during this measurement. And again, you can use a goniometer to assess this measurement or kind of eyeball it. And we do this bilaterally. All right, the individual on the left in the red shirt cannot touch his toes. Okay, how many of you think this is a low back issue? Raise your hand. How many think it's a hamstring issue? Raise your hand, please. Okay. The individual on the right side with the, I don't know what color shirt that is, we'll say pink. He's obviously able to touch his toes, but he's doing it with the compensation of bending his knee slightly, okay? So these are kind of things that we look for in assessing some of our student athletes. Ankle dorsiflexion, this is one of the measurements that we take. 10 degrees is normal. We've seen that happen quite a bit. 20 degrees is optimal for our student athletes. And again, it's often an overlooked limiting factor in the posterior chain. It could add hamstring issues. And these are some things that you can kind of visually see. The individual on the right, or on the left, excuse me, he's got limited ankle dorsiflexion. You can kind of see his right knee is going a little bit valgus. Optimally, you want a offensive lineman to have decent amount of ankle dorsiflexion to be able to comfortably sit in that position, right? Sit in that position, be able to move readily laterally either way, and be able to take on a block or move forward and engage in a block. But that's one of the things that even the NFL scouts that come up and talk to me, if they're interested in a player, that's one of the things that they look for in the athletes. Quick test, if just to eyeball it, some of this we do with our student athletes if we're short on hands or short on students. We just have the kids go up to the wall and we ask them to dorsiflex their toes towards the knee. Okay, 1 inch represents about 10 degrees, so they're able to get their toes 2 inches. That's approximately the 20-degree angle we want to accomplish. Okay, and that's something that even in the high school setting with limited staff and students, you could potentially engage in. Any questions at this point? And please feel free to jump in. If you don't agree with one of the points that we're making here, I'm glad to talk it out with you, or we can talk after I'm done talking up here. Okay, posture assessment. This is the one thing that I really feel I've been doing over the last 6 years. Being able to visually see a student athlete and being able to indicate or assess what problems they have just by seeing them standing. Okay, muscular anatomy, if they're overdeveloped on one side, can cause a overbalance on that one end and create a postural imbalance. Easy assessment. I mean, you want everything to be even, left to right, hips. Get your anatomical landmarks and make sure that they're even left to right, and also lateral. Laterally measure ear to ankle, whether or not they're swaying one way or the other. Looking at this individual, I mean, this is just a plumb line measurement, and this is a pretty good posture for an individual, but the middle slide kind of shows you that his ear is not in line with his ankle, so he's kind of swaying forward just a little bit. And on the right slide, you can kind of tell that he's a little bit off center as well, okay? And may not be a big issue. This gentleman might be healthy. This gentleman might not have any low back or hip flexor issues or anything of that nature, but it's just something to note. Leg length discrepancy, we probably see this maybe one of the most common issues that we see where I'm currently at Bowling Green. And he's just doing a leg length test, true versus apparent. Just a big review. Apparent, okay, there is a measurement issue, but it's not a true leg length discrepancy. I mean, the femur is usually at a shorter. It's usually the femur that's contributing to this discrepancy problem. Okay, but this is a way to figure it out, and by addressing this with a lift or maybe some type of pelvic balance, you can really sidestep a lot of soft tissue problems. Here's an X-ray of an actual person. You can kind of see where the knee joint landmarks are. The right leg is slightly elevated over the left, and you can tell right at the feet. It's creating a lift off the ground. So if you can imagine this person being a distance runner, the amount of stress and load on that right side might cause an imbalance and maybe cause problems left or right. I've seen it happen both ways. Now the gentleman on the right has been riding, or the left has been riding a horse for his whole life. Okay, you got the bow-legged syndrome, the genu valgum posture, and the number 3 is the genu recurvatum. You tend to see number 2 in ladies with the Q angle, and that really sets them up for a lot of potential knee problems. Okay, genu recurvatum, that could cause some other knee problems as well. Number 1, I mean, you guys, hopefully this is just review, and these are just some things that you can point out and hopefully address as well. Lower leg posture, the person has a foot drop on the left side. That person might benefit from an orthotic. Okay, if you identify this and are able to have this person placed in an orthotic or orthosis, that could help them, especially if they're a runner. If they're any active athlete, some support in that area could help sidestep some problems. Good posture on the left, poor posture on the right, things that you can really get keen on addressing and assessing as well. We're going back to this individual. Still looks pretty healthy to me. Same picture, no real change. And then we have the other problems here. Some persons, it's going to have the first model is kind of close to the previous picture. Okay, ear to ankle looks good, but the kyphosis in the second skeletal model it's very very obvious. Okay, the flat back posture, you can tell the normal curvature in the spine isn't there or where it should be, and then the sway back posture is also just an increased forward tilt of the pelvis. And if you see individuals like that kind of reminds me of the from Scooby-Doo, Shaggy's body posture and how he walked during the cartoons. All right. Here, another over-exaggeration. The postures that you see, sway back, lumbar lordosis, thoracic kyphosis, forward head, and good posture. Okay, good posture. I don't see too many individuals standing like at attention like the good posture model. But again, over-exaggeration, just some things to kind of look at. Real-life pictures of a person with some scoliosis. Really, there's some things you can do for a person that has this problem. Some doctors feel, some chiropractors have spoken with me that there are some muscle balance exercises that you can do to maybe help get a more neutral spine. But as far as getting it completely straight, it's not going to happen, or it very seldom happens unless it's a very minimal case. This is another picture of a person with scoliosis, and I've had athletes that practice and participate in games with scoliosis. Here, hyperlordosis. This is something that you might see in your offensive linemen or other individuals. You can kind of see the gentleman with the blue trunks has an over curve of that lumbar spine. The gentleman on the right, not quite as obvious, so he's more of a normal case. Real life kypholordotic picture you can see is upper thoracic is a little bit more rounded than what you'd like to see, and he's got a little bit of lordosis down at the bottom as well. More posture assessments. These are things that maybe just through corrective posture, teaching, reminding an athlete to stand up straight and engage their proper musculature is something that they can address on their own. and the forces at play, okay? One of the things that we worry about is more of the pelvic alignment, the pelvic tilt. If the pelvis is tilted too far forward, that's going to increase the curvature in the lumbar spine and increase the amount of pressure that you've already are experiencing in a very limited area in the low back. If they're tilted backwards, that's going to flatten out the lumbar spine and also create some other problems. But if we could talk musculoskeletal, you got the pelvic on the first illustration here. It's tilted forward, so that's going to put an added stretch on the hamstrings, okay? That means that you either got some tight quadriceps that you can address, and it's also going to create some tight hamstring problems, or put excess torque on the hamstrings. Same goes for the second slide. The opposite is going on the slide, or the third illustration. Hamstrings are too tight, and it's also going to create some unnecessary stresses on the quadricep muscles, if you can see that. For me, quick assessments, I'm going to share with you our pre-participation exam that we do at Bowling Green. But for me, this is, I mean, I can take an athlete and get them on a table and quickly go through an assessment and identify areas of concern within about a minute. And it's just going through all the tests: quad flexibility, hamstring flexibility, low back, whether or not they can touch their toes, ankle mobility, and glute flexibility. Now, all we do for glute flexibility is just get them on their back and see if we can bring their hip or knee up to 90-90 and see if we can, how much we can get the knee over across their midline, okay? And glute flexibility tends to be something that all athletes need to work on. Could you please raise your hand if you are FMS trained or have used FMS at your current setting? Or how many of you have heard of FMS, the functional movement screening? Okay. But how many of you actually use it in your high school setting or clinical site? No? Okay. We started using FMS screening when I was at Southeast Missouri in 2009, and we used it for about 4 years. And it was actually our strength and conditioning coach that headed this up, and he decided to follow this train of thought, this practice, based on what one of the strength coaches that I worked with at Missouri was doing. And at that time, he was with the Atlanta Falcons, and there was a big write-up as to how the Falcons were doing FMS training, and that they were, following it to the letter of the law. And the gist of it was that if an athlete didn't score out of the 7 tests, a minimum of, I think it's 16 out of potential 21 or so, they weren't allowed to advance into the more difficult exercises. They had to do corrective exercises, they had to do technique work, and essentially, just stay with the correctives until they got a better score on this FMS screening. For 4 years we did this, okay, and I helped do a lot of the screening, and I liked it. I liked the concept. I liked the idea of it, and let me just see what the next slide is. Okay, we can go back to that. The debate was this: our head coaches were bringing in kids from JUCOs to play at SEMO, and they weren't being allowed to lift because they were doing terribly on their FMS scores. Okay, we had a couple of guys that were in the single digits, which is not good if you're doing following this FMS philosophy. We had an offensive lineman and a defensive lineman that both scored a 9 on each one, and they ended up getting in a fight at practice one day, and it became the battle of the 9s. I mean, it was that bad. I mean, so we had to make light of the score, and so the coaches, they wanted to change, and they wanted kids to lift, and the strength coach really wanted to stick with this. So they were butting heads on how to train the athletes. Ultimately, I think if it's a coach's team, a coach has the right to, have their team trained as they would like. And as a strength coach, you have to be flexible with your own methodology and your thought process. So this was constantly going on, and our strength coach kind of adapted a little bit, and he went from strict FMS to modified FMS, and I think that's still how they train their student athletes down there. He's the only strength coach that I know that has implemented this in the college setting that I've worked with, okay? The research quandary, okay. We're doing this for 4 years, and I'm noticing through my injury report and our data collection that we're reducing our soft tissue injuries, hamstrings, quadricep injuries, any soft tissue injury that you can see during the season in football, we're being reduced. And I thought this would be a great research project for one of our graduate assistants. So I gave him all of our data, and he also got the data from the strength and conditioning staff, and what they were doing was comparing the scores to the injury rate that we were seeing. And there was no correlation. There was zero correlation, and I was a little bit upset. I thought that we would actually find something in there, with all the numbers we put in, and it was a decent sample size, over 3 years, 100, athletes. You would think you'd come up with some better information than that. The only correlation that he found was that this test, I don't know if I can point it out, the rotary stability test, which is this thing even working? There we go. This test right here, which measures core stability. The worse you did on this test, the more you were inclined, or you had a higher rate of injury that we saw. Okay, so if you did poorly, you got a 1 on this, you were more likely to get injured. And I thought about it, I'm like, wow, I mean, everything else doesn't tell us anything, not even the 90-90 or the other tests that we were looking at. And these are all the 7 tests that FMS does, okay? The squatting, the stepping over the band, the forward lunge, reaching behind your neck, which measures upper extremity flexibility, 90-90, and then the push-up maneuver. So I was a little bit disappointed, but did make sense to me after I thought about it. The rotary stability test measures core strength. So if you're lacking any significant amount of core strength, you're probably more prone to injury because you're not able to transfer the forces from the ground through your core, through your upper extremity, especially in a sport of football where there's a lot of collisions going on. This is what we do at Bowling Green. We do some structural tests, the true versus apparent leg length discrepancy, hip height and sacral rotation, the Thomas test, the Ober's test, Ely's test. Actually, I just stick with the Ely's test. Hamstring 90-90, sacral fixation, ankle mobility, and low back and toe touch maneuver. And this is actually a grid that we take most of our teams in, take them through. They get whether or not they need improvement. We don't actually score this. It's just something that we may put down a measurement and address it with some corrective exercises. And it's worked well. I mean, we've got at least maybe 15% of the football team that has corrective stuff, and they come in religiously. So they've seen improvement in their mobility, seen reduction in their soft tissue injuries, and have also improved in their athletic, performance as well. If they can stay on the field, they're going to see that as a positive. We do the other movement part of this is the single leg squat, overhead squat, and we do manual muscle testing as well. Whether an athlete is able to do a single leg bridge or a single leg RDL, and we've also incorporated the rotary stability test, which is that test we just mentioned about on the FMS measurement system. We also incorporate some dynamic rhythms as corrective exercises. You guys may not be able to see this, but I have a couple of rubber bands on my wrist. But all I'm doing is, if you can kind of pretend, if you can't see this, I'm just expanding the rubber band, okay? And that's how we understand our tissue and fascia and tendons to be. And so over time, what's going to happen to this band if I keep, stretching it, expanding it, time over time? It's going to stretch out and increase in length, okay? Or it's going to get longer, okay? And that's our goal with these dynamic rhythms. And the person on the right is working, or on the left, excuse me, is working on hamstring and hip flexibility, making sure that the hips are facing forward. And the lady on the right is also doing a modified version of that. And we have these athletes come in and do something like this, maybe 3 to 4 sets of 20 repetitions each side, just to get them loose. We do a lot of other work with them, but this is just an example of some of the things that we do with our student athletes. This individual is doing some dynamic glute rhythms. Okay, so he's going to be doing, assuming a glute stretch position. and he's gonna kind of lean into it and then come back, lean into it and then come back to try and work some glute flexibility as well. The illustration on the right, that's the position we have our athletes to do a quadricep rhythm. They're going to be kind of leaning back into the quadricep and coming back nice and gentle. This is kind of this is not, we're not trying to create a dynamic stretch. We're just kind of trying to create a nice little dynamic or slow tug of the muscle so it'll adapt over time to the length we want to try to get it to, or loosen up some of the muscle where we feel it's causing a problem. So what does all this mean? You know, there's some corrective exercises that you can do with your athletes if you can identify some of the problems. Limits and range of motion, you know, once you address them, can alleviate or eliminate some of the soft tissue problems. You have to be balanced, okay? You need to address the core, you need to address the flexibility issues that come along the way, and you want to, I mean, that's essentially the goal. If I can just read that verbatim. The goal is to have a more sound, a core strong, balanced, flexible, relatively speaking, because some athletes are going to be tight most of their career athlete. And these can, if you're doing, you know, working with coaches, student coaches, or strength coaches, they can include this in their warm-up. You know, this can kind of be the pre-participation routine for your student athletes. And once you kind of coach them on what to do, they can essentially handle it on their own. And we typically measure a student athlete once every 2 to 3 weeks, just to make sure they're making progress and not digressing. And they can do this in their room. They can do this while they're watching TV. They can do static holds while they're watching TV. And by addressing this problem, you know, we have seen tremendous benefits from that. This is kind of just the gist of the dynamic rhythms. They're addressing the limits in the range of motion. They should be gentle to the point of tug and restriction. They should not be painful. I mean, if you got a crazy athlete who's going to, you know, work hard and run through a wall for you, you may need to put the restraints on them, because this is something that's supposed to be handled nice and easy. Strict and form driven. Okay, you don't want an athlete, if I'm trying to do a dynamic rhythm, I don't want my hips opening up. I want them to be going forward and linear. You can do them multiple times throughout the day, and just like I said, 4 sets of 20 to 30 repetitions each body part each session that we're trying to get the athlete in for. Dynamic to static. All right. How many of you guys are fans of static stretching still? I like static stretching. I do. I still do a lot of that. I think athletes, you'll have some schools of thought, some student athlete or coaches do not like to do any type of static stretching. Some athletes feel they need to have static stretching. As far as my belief, I'm a fan of it. If a kid needs to spend some extra time after a dynamic warm-up and stretch, that's great. We currently have a new strength coach at BG that Coach Jinks brought up with, Billy Yates, who loves him some warm-up. I mean, that gentleman, I mean, our guys are after 45 minutes still warming up. So that's a tremendously long warm-up event. And I've told him that he loves him some warm-up, and he laughed about it. So, but the dynamic movements, I think dynamic exercises are a benefit to the student athletes if they're able to get into the positions appropriately and not exacerbate or make a position worse for themselves. Okay, RG3 on the left. Gentleman on the right, he's got a little bit too much oil on his body, but he's got a good squat form, right? RG3, can you guys see his knees? Remember, RG had some problems with his knee, continues to have some knee issues. You could kind of tell RG3 had a little bit of a genu valgum issue playing, even in his days at Baylor, okay? And I wish him the best of luck in his career, but that you can kind of see that being a predisposition for some knee issues. And watching form and technique is always important. Soft tissue therapy is one of the things that I've worked on, and I spent a lot of time researching and practice. For my students, when I teach, when I'm bringing in graduate assistants, talking to my staff, talking to students, I always preach that the site of pain is not always the cause of the problem, okay? If we got knee pain, I know our practice as ATCs has always been to address the site of pain. We're going to do some stem and ice on you, and maybe do some strengthening around that area. But that was kind of it. We need to kind of think outside the area of injury. Okay, knee pain, what does that mean? All right, is there some quadricep tightness that we're looking at? Are there some masses of tissue contracture along the quadricep? What's the flexibility like? What's your quadricep range of motion like? Is it hamstring tightness that's contributing to this? What about the pelvis? Is the pelvis tilted forward, which would mean an overtaut quadricep muscle? Or is it tilted backwards, which could mean the opposite? Hamstrings are tight, putting a lot of excess stretch on the quadricep. And then what could have contributed to the problem? I mean, if you got a distance athlete that has all these problems and is experiencing knee pain, kind of the same, workup as well. Flexibility, posture, ankle mobility, and see what else you can come up with. Posture, limits of range of motion are also some things to contribute to that, and also head to toe. I mean, that's the one thing that we try to practice with our program. Let me see what this next slide is. Ooh, wrong slide. Okay. Muscle fascia is very intriguing. I know that there have been more so recently some research in the area of muscle fascia. And what a fibrous benefit it is to the body, how it supports the muscle. But I don't know that it's been actually given the weight or importance of how it actually contributes to movement. Okay, you've got a lot of experts that do myofascial release, a lot of people that do myofascial therapy. I've attended various clinics pertaining to those topics. But it's something to think about. I think there was a paper that I read where there was an athlete. The illustration on the right kind of gives you the patterns or the pathways of how the fascia tends to run within the body. And there was actually a cadaver that was they studied the cadaver. There was a history of the person being a baseball player. And there was a more thickening and broadening fascial layer on the right side, and he was a right-handed pitcher, than there was on the left. So what would that indicate to you? We're not talking about muscle imbalance. We're talking about the muscle fascia itself. So, and to me, that was pretty enlightening. I mean, that you're not also worried about muscle development, but you're also worried about the muscle fascia contributing to the limitation as well. And left illustration just kind of indicates the train or the myofascial trains that the pathways that it's followed. And the Spider-Man looking character on the right is kind of how the fascia operates. Okay. Now we do Graston technique at Bowling Green, but we just don't. When I first got there, that's all that the staff was doing, just Graston work. Well, I really felt we needed to address that more so. If we're going to do Graston, we need to incorporate that with some dynamic stretching. We need to do some soft tissue mobilization as well to really reap the benefits of what we're trying to accomplish. But the illustration on the right kind of gives you an idea. Your fascia or the tight spot on the right shoulder might be affecting an area over the left knee. Okay. Do any of you use these devices, foam rollers? Raise your hands, please. If you PVC is where it be. That's what I tell my athletes. Painful, but very beneficial. We actually use shot puts in our area just to get a little bit more focal soft tissue mobilization. And I always tell our athletes that if it's going to be painful and that they might see a white light, but don't go into the light, okay? And if they pass out, we're just going to draw a chalk line outside their body until they get up. So. But anyway, I'm a firm believer in all these devices. We actually have a soft tissue or a stretch table, as pictured on the left, that I incorporate into a lot of our mobility work. And it does take a little bit of time. And I know as athletic trainers, time is not something we have the luxury of having too much of. But for some athletes that are in need of it, we'll spend the time with them. And it's usually maybe a 10 to 15-minute stretch therapy session following some mobility work, following some Graston that's been done the previous day. So. I wanted to tell you about this case study, and I'm almost done. So This is, I thought, very unique and kind of ties everything together. This gentleman on the right is, you may or may not have heard of him. His name is Christian Cantwell. I worked with him at Missouri when I was with track and field, and he's an Olympian. I don't know how much money he makes these days. I haven't spoken to him for a while, but his case is pretty interesting. When I first got to Mizzou, of all things, this gentleman has like about 500 pounds on the bar, and strains his pec. So everybody was really concerned about this individual, and we had 4 coaches at the doctor's office with me to see what was wrong with Christian, and it just was a minor pec strain, but it was something that we needed to address in rehab. He suffered a hand injury later that season, where he tore the lumbrical muscles in his palm. Learned too much about hand musculature after this case, but he couldn't throw, and this was potentially, for a thrower, a career-ending injury. And he still had about 3 years to compete in the college setting, and he kind of just shut down because he was not able to throw. We were working with a massage therapist. We were seeing an orthopedic hand specialist, and eventually got him to throw again. But the individual did have an anterior pelvic tilt, okay, tight quadriceps. I mean, Christian was just tight all over the place. I've never seen so much white muscle fiber on a human being than on this kid. 6'5", 330, that's a good size individual. So, and he did have some limiting quad range of motion. Hold on. So going back to Esteban, the gentleman with the killer thumb, he worked on Christian, but he didn't just work on Christian in the right pec. He worked on right hand, right forearm, right bicep, right pec, right iliopsoas, left quad, left anterior tib, all the way down to his left toe. He strongly felt that the right hand injury, because Christian had suffered a toe injury the year before, okay? And Esteban strongly felt that the left toe injury in some shape or form contributed to the right hand injury, okay? And at the time, I'm thinking, Esteban, keep your thumb to yourself. I don't really believe what you're saying. But now I can kind of see that, okay? And I'm not really trying to stir up a bad batch of Kool-Aid, but these are some ideas that were thrown out at me, and being in a more, I guess, a better state of mind, I can more readily accept. And these are the credits. You guys have any questions for me at this point in time? Because I'm done talking, so. If not, I'm going to hang out here for a few minutes. You guys can kind of approach if you feel the need to. But thank you to Spats. I appreciate it. Yes, sir. Go ahead. Yeah. Everything. PNF, static holds, rhythmic stretching, anything that you can imagine, we do it. And we do a lot of PNF as well. So whatever you kind of feel, it's just one of the tools in your bag, whatever you feel is appropriate at that time, depending on how bad the athlete's range of motion is. That's what we use to incorporate. But we do a lot of PNF as well. Very effective, very effective. Anybody else? Well, thank you to Spats. I appreciate being down here. I love the Valley. Valley's my home, and the island's one of my favorite places to come. So thank you guys for your time. Did you take my thing? I thought, do you know if I can my jump drive? Oh, no, it's right here. I'm looking on that computer. What the hell am I doing? You think it's okay to take it, or? Oh, wait, come here. What's his name? RT? Regular.
Okay, guys, before we get our last two speakers, we got Spanky Stevens and Hondo Schneider coming up. Can I get all the SPATS committee members up here, please? I want to introduce everybody that puts this on. I know I say it every year, but putting this clinic on is a tremendous effort. And so I want to introduce all the people that do it. Of course, my name is Jeff Darr, and I'm the chairperson of the SPATS committee for the Valley Athletic Trainers Association. So this is my committee. Stephanie Becker, she is the one that deals with the BOC, takes care of all the CEUs, and it is a huge, huge, huge thing that she does. Marie Thompson is the one, we call her the hammer. She's the one checking IDs at the registration desk. She's at La Jolla High School. Stephanie's at Donna High School. Natalie Coronado. Natalie Herrera. She just got married last year. Anyway, she's the one that puts together the program. She takes care of all the speakers. She does all the behind the scenes work, getting these speakers up here on the stage for you guys. Bob Aparicio, our outgoing VATA president, he's the one that handled all the vendors out of here. And he does a tremendous job. We had a great group of vendors this year, and I can't thank him enough for handling that for me. Susan Detweiler, and Bob is now retired. Used to be at Mission High School. Susan Detweiler, Edinburgh High School, handles all the money. She handles all the finances. She's also the treasurer for the Valley Athletic Trainers Association, but she's the one that takes care of all our finances. And last but not least, Kurt Flugel from McAllen Memorial High School is our swag coordinator. And he takes care of all the t-shirts, all the goodie bags, all the stuff that you get inside your bag, koozies and everything. And I want to thank him for doing that. So this is our SPATS committee, and I appreciate everybody's help. We're going to have two more speakers. John Herrera is at San Benito High School, San Benito's 9th grade campus, and he has done a great job as our master of ceremonies up here. So I'm going to turn it back over to him, and we'll have some big door prizes after our last two speakers.
Ladies and gentlemen, now introducing Mr. Spanky Stevens. There you go.
It's above my pay grade. We get the big room this morning. Wow. Hondo and I are usually over by the men and women's restroom out in the hallway on Sundays talking. So welcome. I hope you've enjoyed this as nearly as much as the rest of us have. And the beauty of this conference compared to all the others is you get to come as you are, take what you need, take it back home with you, and use it as you need to. There's been some wonderful talks, and there've been some informative talks, and the party and the those of us that are members of the Valley Athletic Trainers little dolphin watch ride last night was a lot of fun. And this group of people that were just introduced to you are not only worked their tails off to make this happen, but also just wonderful people. And the one good thing about our profession is that we work really, really hard. We all have, and also, but yet we like to have a good time as much as anybody else. And it's like a brotherhood and sisterhood. Our profession is. We all know each other, even though in the heat of the battle we want to win, but in time of need of our colleague across the field from us or across on the court with us or whatever needs our help, we'll give unconditionally. And that's the uniqueness of being an athletic trainer. And being in Texas is even more unique. We continue to raise the bar and all that we do to make it, one, easier for you to do what you do best, so that you don't have someone looking over your shoulder that doesn't know shit about athletic training. And there's a lot of people out there think they know everything about athletic training. I've dealt with them, you've dealt with them, and in the end, it's always an aha moment when they find out that what you told them was spot on and confirmed by a physician. As we go into another year and ending a school year, there's a lot of things that are coming up for the next fall campaign. TSATA and UT Southwestern Medical School went to the UIL and wanted to collect data because they were getting hammered by the media because they had no idea how many concussions were in the state of Texas. And we went to Dr. Brodeup and Dr. Harrison, made our proposals, done, and so we've come up with them kicking and screaming and limiting the number of people because they feel like that the Coaches Association in particular, both men and women, feel like we're trying to stop athletics in the state of Texas. And I know, we're not trying to kill our own job. We're just trying to make it safer and better for our student athletes, both male and female. So we formed a collaboration. It's called Context. It consists of the TSATA, UT Southwestern, the UIL, and Medical Innovative Labs. And Medical Innovative Labs is a group out of Austin that I brought into the deal because I wanted to make it as easy as it could be for you as athletic trainers, should you choose to be part of this data collection that we're going to start this fall, hopefully by August. We're going to run a test project on the app. It's going to be done early next month. I'll get 10 to 15 of my best friends to put fictitious names in there, send the information to UT Southwestern. They decipher the data and everything. But I made this app, and I had them make this app as user-friendly as it could be. And also to give you that participate in that feedback on your athletes that have concussions. And this data collection is going to be done on once they've returned to play. And we're going to see that, it's a kind of a background. It goes back to the concussion law in 2011, 2015. We started the talks in October in Dallas, and then we went to Austin, and then back to Dallas and stuff, and to where we are today. Also, our objectives is to make all the sports safer through better concussion tracking. And you ask, well, how is that done? Well, right now, what tracking is being done mainly by the NFL and other professional sports teams and stuff like that. They're given a better idea about where the concussions happen, where we thought a lot of it was head-on-head contact or whatever, but actually the field of play has become one of the leading culprits in causing concussions in professional sports. So also the app is just a reporting system, is that once you have a student athlete that receives a concussion or is diagnosed with a concussion, and you've gone through your return to play protocols and stuff, and they've returned to practice and play, then the app comes into play if you want to volunteer your time to do this. And we need volunteers, trust me. So you touch this and you come up with this, and these are the questions that are pretty straightforward, and they take as much time as that. You notice that the name of the athlete is on this. We did this for you, but yet when the app is received, when the information received by UT Southwestern, the name of the student athlete is not there. This is only for it goes into what they call a box. And for you that say you're at Edinburgh High School and you want to volunteer and be part of this data collection, that later on down the line, these are some more of the questions, and I have taken this, and the most time it has taken on one has been 8 minutes. So it's not very time consuming. And then your past history of your student athletes. And this is yours. All this are all your athletes that when you get on the app and you want to see when the last date that one of your athletes had a diagnosed with a concussion. This goes through each person that you send in data on that you have a reference to, but they don't. They know that it came from Edinburgh High School, but they don't know who the student athlete is. They only know the sex and the height and the weight and the incident of injury. And then, it will give you a graph drawing of incidents of injury for you at your high school as you go along and doing it. We're hopefully that we can also get some physician hospital clinics to participate in this, so that see much larger number of student athletes than with incidents of concussion. This is going to be done only licensed athletic trainers and physicians can enter this information and will only be able to receive the app. It cannot be used by coaches, nurses, whatever. And so those people that work in outreach programs across the state can represent like 2 or 3 schools and stuff. And so this is the beginning. And so we're going to start this up hopefully by August the 1st, before volleyball and football start. And this will include cheerleaders and band members should you see them too. So how do you get the app? Well, you send me an email and say you would like to participate, and then I will send your information to Tom Stevenson, who works with MIL, and he's the one that's developed this app, and we've worked together hand in hand in doing this. And it's also, should the UIL mandate that you send in information on student athletes that you have to put into the hospital, that part of information that would be sent, that you would send to the UIL, we can add to this app further down the line once they decide whether they're going to do it or not. They're talking about it, but yet they do a lot of talking. First, they were going to mandate every one of you to do this. Then first they didn't want to be part of it. Then they wanted to mandate everyone be in charge of it. We said, not only no, but hell no. Then we said, then they wanted to be we're just going to do volunteers. Okay, but you said you wanted to mandate it. What do you want to do? Well, what they did, they took a draft that UT Southwestern gave to everyone, and it was just a draft. It wasn't what they wanted to do, because the draft said it was a volunteer program, which we first started out to be. And in our last meeting with the UIL, Dr. Harrison said he's going to mandate it, and he makes a presentation to the Legislative Council as a volunteer. So we're starting off as a volunteer. So we're going to need lots of volunteers. And no, this is all HIPAA compliant and compliant to every other chance of sending information in for data collection. It's going to be unique because we're opening it up to the entire state, and there's never been anything done on this magnitude concerning concussions in the United States. So once again, we're first in line in doing this. And Dr. Bacher, who's the head of UT Southwestern Traumatic Brain Institute and Healing Center, is also co-chair of the NFL Head, Neck, and Spine Committee. He's also a former baseball player at Texas. So he and I have known each other for 40-something years. So it's in our best interest. He would never do anything to hurt our profession or what we're doing. We've made stopgaps to make sure that it's informative for you, but yet informative for them. It keeps a tracking record for you that you can go online, go onto the app and see where your athletes are and the number of concussions that you have throughout the year. We need volunteers. How do you volunteer? You go to our website, see my email address, trainerex@earthlink.net, trainerex@earthlink.net. Send me an email that you'd like to participate with your license number, and then I send it to Medical Innovative Labs, to Tom Stevenson, and then we go from there. So that's the newest thing that we're working on now. And here's all athlete information will be de-identified and fully protected by HIPAA and any other was FERPA and any other laws that we have to follow in doing this. And that's Tom's information, and our involvement. And I think we've made a commitment, and in doing things that are in the best interest of our student athletes, participating in this program. It's fully on a volunteer basis, but I would love to see between 100 and 200 licensed trainers throughout the state to start off in this program, to get into the app, and so that we can start collecting information, and word of mouth of how easy it is, and everything will spread, hopefully. The other thing, the newest thing on the market today is the Dallas Morning News, and this past week, through legal ways, is gathering all the school districts within 50 miles of the Dallas Morning News, their information on their concussion oversight team, the return to play protocols, whatever information it is, to make sure all these school districts are compliant with the law. 3 years ago, I spoke before you. You could go to texasconcussionlaw.com. On there, Bucky Taylor we set this website up with UT Southwestern, so that those of you that had questions of whether you're in compliance with the law, that you could send your information to Bucky, and Bucky would give you feedback on exactly how to do that. You can still do that today, because I can tell you that once they start doing things in Dallas like this, it'll spread to Houston and San Antonio, and as you know, we'll work in the Valley and El Paso and up into the Panhandle. So there's some newspaper that wants to get involved in this, just like the Dallas Morning News. So when you get back to your school and you have a few minutes and stuff, go back over what you set up in 2011, 2012 concerning your concussion oversight team and your return to play protocol. So make sure they're up to date. You can go to the CDC website and stuff, especially on return to play protocols and stuff like that, to update your information and stuff, just in case somebody in the Valley or somebody in Houston or San Antonio does the same thing that they're doing in the Dallas-Fort Worth area, and they're in a panic mode there. Trust me, Dennis and Bucky and myself have been called by numerous school districts and athletic trainers. Look at this, see what you think, and stuff like that. And we've had to tell some of them, you need to change this. One thing you can't have as your oversight team physician, I can tell you right now, is a chiropractor. If you have that, you need to find somebody locally to be on your concussion oversight team. I know some school districts have that, and throughout the years, people have asked me about it, and I tell them you need to get it changed, and they end up changing it. But if you have one, I just want to say that you need to change that back into what we're doing legislatively and stuff. We're looking at a couple of things. One of the things is we're still working on TEA recognition and get the athletic trainer spread out in different areas in the name to be added in areas that we work in. Also, that one of the things that and it was brought up to me on Thursday during our sports medicine class, that somebody asked me, what are we doing to protect the athletic trainer about club sports? Well, there's not much we can do about that unless it's hopefully that we're considering legislation. And I talked to Representative Price, Chief of Staff, on Monday, that we had lunch together, that to look into the feasibility of demanding or mandating if we could mandate club sports that have their games either on county-owned land or city-owned land or in a school district gymnasium or baseball field or soccer field or wherever they're hosting these fields, that if it is state funded, that they need to provide a licensed athletic trainer to be there on site to look at your athletes, because there's not much else we can do. And hopefully that they're doing some research on it and stuff, and hopefully by August or September we'll have a better idea of whether we're going to try to get this passed in the 2017 legislative session. You know, you know, it's hard to not know on Monday what you're going to see, what happened over the weekend that was out of your control, that you weren't part of, and whatever. So this is probably about the best that we can do. And once we find out, you know, some of these club teams are now using athletic trainers. The more elite teams are using athletic trainers that they use out of outreach programs in the larger cities and stuff like that. So we're just trying to make it uniform all over the state of Texas, that if anything's done on state land, state funded land, and no matter whether it's with the county or the city or with the school district, that there'll be a licensed athletic trainer on hand for that. And it will provide jobs and money for somebody that wants to work over a weekend. So as far as TSATA, this is what we do. Make sure you look at your COT and your concussion oversight team and all your return to play things and stuff, and just go make sure you're up to law. Go, if you're in doubt, go to texasconcussionlaw.com and you will be able to that website, and Bucky will answer your questions and stuff. All right. Any questions for me? Yes, sir. We're hoping to get as many people, any licensed athletic trainer, to be part of this. And if a middle school person wants to be part of it, they can be part of it. So it's not limited to, it's not limited to high school. So if that's your question, my hearing's not what it used to be, and my sight is damn sure not what it used, because I had to go get it to work this little Dumaflachi. That's what they used to call it when I grew up. What, you got that Dumaflachi with you? Yeah, here it is right here. All right, what else? Any other questions? Thank you, and have a good time and a safe trip home. Thank you, sir.
I know.
Am I on? I'm not on yet. Hello? Am I on? While they're doing whatever they do up here, I don't know what it is. I want to tell you, Spanky, y'all didn't know this today, and I could be wrong, but if I'm not mistaken, we made history at Spats today because that's the first PowerPoint presentation I've ever seen Spanky do. Total history today. Am I on yet?
All right, our next speaker is Mr. Hondo Schneider.
Thank y'all. Happy Father's Day to those that are fathers. And it is we are what we are. It's the best profession, really. Okay, same old medical advisory committee stuff. Spanky took one thing off. I don't have to talk about the UT Southwestern thing because Spanky did that. I'm just going to elaborate on that real quick. I was at the meeting in April when we discussed that with the doctors, and I went to bat for us because the Dr. Sabor, whatever her name is, I thought they wanted too much information, and I said, and then Jamie was telling what Spanky was talking about, how Jamie, they initially wanted they were going to mandate that we do it as athletic trainers. And just for the record, I threw a fit about that in the middle of the meeting. I thought, you can't make us do that. So it's a volunteer thing. It's not mandatory. Okay, here's the members. Most of y'all have seen some of this. Some of y'all are maybe first-time listeners to me. Maybe some of these doctors you work with, but they're all good people. And then, as you know, last year we had to add athletic trainers to the medical advisory committee and another physician. And that was due to a sunset review of the UIL. And Spanky's friend, Senator Ford Price, that he refers to a lot, that had a lot to do with the concussion bill and stuff. He was the oversight member of the sunset review for the UIL, and they wanted us to add a doctor, another physician, and 2 athletic trainers, and then the 2 coaches association representatives, D.W. Rutledge and Sam Tipton, from their respective coaches associations. They used to have voting privileges. And in case you don't know this, they no longer have voting privileges on the UIL Medical Advisory Committee, so we don't have coaches making medical decisions for us anymore. And okay, so they have input, but they do not have voting rights anymore. But they did at one time. And then I like the little room better than this big room. Valerie Duran. She's been at Midland High. She worked in Fairbanks, Alaska for a couple of years. She's been at Plainview. Now she's at North Crowley. And she's a good friend of mine. I put her on the committee. Actually, I put her and Buzz on the committee. I got to handpick the trainers for the committee. The UIL didn't do it. They let me pick them. And but she's my shoulder expert. And when we talk about, how many of y'all have heard about the new pitch count thing coming down the pipes? I'm gonna elaborate on that when I get to that slide in a little bit. But anyway, I put Valerie in charge of that, and she's done a fantastic job on that. And then that guy at the bottom, we just talked about him. He's the rep from the TSATA, and he comes to our meeting. He wasn't at the last meeting, but he comes to most of them. Okay, subcommittees. Dr. Fenrick, he's the pediatric cardiologist at the top. He's the one who makes the cardiac awareness form on the physical packet. Any changes, which we're going to talk about in just a minute because that form changed this year in case you didn't know it. And I'm going to talk about the changes and what to do and what you don't have to worry about and all that here in a second. But anyway, he's the one who does that. Dr. Seals, he's a pediatric neurologist at San Antonio that's on the head committee. Head committee, me, I'm in charge of that. And then history is Dr. Hergengroder, who's a sports medicine guy out of Houston, and he's like one of the most intelligent people I've ever been around in my life. He is something else. And we don't have breakout meetings at our committee. When we meet as a UIL committee, we don't have breakout meetings and this and that, but when we have issues, the members of each subcommittee, we coordinate with each other over email and telephone, and then bring back our status and our report to the meeting. And this is a little bit of history of what we think some of the things we've accomplished over the years. And I know it was hard to fit on one page, and you can look at that. And you know, one of the biggest thing that we've had to deal with over all these years, and I've been on this committee 16 years, I think, is the concussion thing has been our biggest nightmare we've had to deal with. I mean, we started out back in the old days, and we had the concussion management protocol. Remember when the UIL sent everybody, got a little card to carry in your pocket and all that kind of stuff. And then Natasha's Law came up a couple years ago, and then we had to incorporate our concussion protocols to accommodate the law. And anyway, that's the biggest mess we've had to deal with. Okay, this slide, you know, I like to show this slide every year, and I change the picture. But every year, year in and year out, I get telephone calls. Okay, I've got a softball girl. She's 6 months pregnant. We don't want her pitching, but her doctor says she can pitch. What do? You let her pitch. I mean, the UIL will not tell them yes they can or no they can't. It's going to be between the parent and the doctor and y'all. And hopefully, sometimes smarter minds will prevail. But there's an old fella named Will Rogers. How many of y'all know who Will Rogers is? Heard of him? Well, he's got one of my favorite sayings is the one thing about common sense is it ain't so common. And there you go. And then I got a little thing to go with that. And then if you really think you're pregnant, wait until tomorrow to tell your mother. Okay, steroid testing. We all know what it was. And it's still here, but it's not here. How many of y'all know that? Okay. Anyway, at the bottom is the stuff in the red is what it is now. We had 0 positive tests because we did 0 tests. We saved $1.6 million. And the thing about it is you still have to have them sign the steroid testing form on the physical packet because it's still in the books, but there's no money to fund it. So, I mean, it's politics, y'all. You still got to do the form, but they don't come to test, and that's like the greatest thing that ever happened to me is not have to show up and go round up kids and look at their piss all day in the glass, you know. Okay, the pre-participation physicals. How many of y'all know that there was last-minute changes on that just within the last couple of months? Okay, well, we knew that it was probably going to come, and I kept fussing with the UIL about getting this done, and Bubba over here was giving me shit about it a little while ago, and I'm just going to say it, and I said, we knew it was going to come, but as the committee, we recommend changes, and our goal is to recommend them in October to have it done and completed by the end of January. So those of you people who are like way ahead of the ball game that print your forms like in February, you know, you're go-getters. I don't do my forms until April, but we try to have it ready for y'all to print by then. But anyway, they wanted to make some changes, and some things came down, and then Dr. Fenrick, who's on the heart guy, he was having some issues about how he was going to change that. But anyway, if you look at your forms, on number 4, they just added that one little question. How severe was each one? If you look at that. And then at the bottom, right above where you sign that everything you state is true, and if you lie, you suffer penalty of the UIL, which I don't think they've ever issued a penalty for someone lying on their form, because there's probably 40% of those physical forms y'all get are signed by the children anyway and not their parents. Y'all agree with me on that? They show up at the mass physical and, oh, mama was not here, and they just start signing crap. We all know it. And is it legal? No, but unless something ever happens, nothing's going to happen. We all know that. We've all been through that. But anyway, am I lying or not? No. Anyway, at that bottom part, that part in the red right there was added in I don't know why it was added, but they did it in the office. It wasn't done by our committee. The medical advisory committee didn't do that. The UIL staff did that change. Time out. But anyway, I called him on this, and Mike Carroll, I don't know how many of y'all know Mike Carroll. You know, he knows everything. I'm just kidding, Mike. If you heard me, I don't care if you heard me say it or not. But my phone started ringing off the wall. Well, all these people printed their forms, and I'm getting phone calls and emails, and I'm like, I don't know why you're getting them. You didn't do it. But I talked to the UIL the day that this crap storm hit when everybody started finding out about this. And we had a discussion, Jamie Harrison and I, and the athletic director at the UIL, and Mark Cousins, and then a little bit of discussion with Dr. Broad that, hey guys, this is late. Some of these people have printed their forms, and granted, printing up 500 forms isn't a whole lot of money, but it's still a matter of getting it done. And we keep adding paperwork, so the paper, it's still, it's almost getting to be like an NFL physical now instead of a high school physical with all the paperwork we're doing. And anyway, we had that discussion, and we agreed that if you already had printed your forms and you were already handing them out, that they were going to be good for the 16-17 school year. And the next time you go to print, you print the new form. So if you have the old form or the new form this year, you're good either way. I like to talk about this one every year too, because especially down here in the Valley, El Paso, OJ, y'all know where OJ is? Ojinaga, Presidio area down in there by Big Bend. Everybody says that if you're going to take a physical for a student in Texas, it must be a licensed healthcare provider from the United States, not from Matamoros or Cunha or OJ or Juarez, because if there was any kind of litigation, their license in Mexico is not worth the paper it's written on over here, and you've got no leg to stand on. So don't take one. Like, how many of y'all have had foreign exchange students? Yes, we've all had a bunch of those. And they come with the physical from over there. I don't take those. I make them, they need to have a physical from a licensed healthcare provider in Texas, even if it's a chiropractor. Okay? Safety training, again, we always got to talk about this. And referring back to what Spanky was talking about earlier about the Dallas Morning News thing, trying to stir up another crap storm about the COT and all that. And in case y'all know it or not know it, all your coaches' compliance information, like have they been certified in CPR, AED, first aid? Have they done their concussion training? Have they done their rules compliance program through the UIL? First-year coaches have to have the first-year class from the National Federation of High School Coaching, the Fundamentals of Coaching course. And when you sign on with the school district, you have to sign the professional acknowledgement form. All that is public record. That's not protected by privacy laws. And if you have a parent who has a kid who's been injured, has a concussion, or your local newspaper like the Dallas Morning News, San Antonio Express and News, or whoever, they want to come and do an open records request and want to see every coach's compliance record, your school district has to be able to provide that to them. I think the legal time is 10 days or 2 weeks, something like that. But that needs to be on record. And your doctors that are on your concussion oversight team, they are also required to have concussion training. And that has to be on file. And I would be willing to bet you the money in my pocket, which is more than I got a couple of $100 in my pocket probably right now, that 80% of your doctors on your concussion oversight teams are out of compliance on their concussion training. I'll bet you $100 if you go look at that. And that's something that I don't know if your school district puts you in charge of, but ultimately that responsibility falls on the superintendent of schools. And that also, that ranks right up here with the compliance with Senate Bill 82, unless you are, and a lot of us are, that, you know, that unawful word that you get, the designee, the boss's designee, which a lot of us are head football coach's designee or whatever. The superintendent's ultimately in charge of that. And the other problem we have with complying with Senate Bill 82 is that there are hundreds of superintendents that don't even know what that is. I mean, literally, you get down to little schools, they don't know what it is. And I would almost bet you that my superintendent, he has this t-shirt that says, I don't need an encyclopedia because I know everything. One of those kind of guys. He doesn't know anything about this. And then we had an old athletic director about 4 years ago, and I'm from a 6A large school district. He didn't know what that was. And so staying in compliance with Senate Bill 82 has got to be a real problem. And the only time it's ever going to become a problem is when there is a problem and some lawyer finds out that there's a Senate Bill 82 and you as a school district weren't in compliance with it as far as doing the safety training. You know, all the kids have to do the PowerPoint. They have to sign a piece of paper. You have to turn in they're supposed to turn in a roster and a signature page to prove that they did that, and it's supposed to be on file somewhere. And again, if mom and dad comes in and says, my kid, say, suffered a heat exhaustion episode or something like that, and they found out about this and they want to know if had taken that course. Well, somewhere right on there it says, maybe, let me see if it's the next page. Yeah, right here at the top. Here's what happens. So you got football. Football starts 1st of August. Well, they don't get the kids until the first day of practice. I mean, we all know that they all cheat and they all do stuff before they show up to practice. I mean, we all know they meet. We all know about that. Anyway, the strange thing about this is I've been trying to get it changed and make the safety training PowerPoint a requirement to be done before the first day of practice. But in theory and according to the rules in the book, you could play football all season, and then after spring training, the week before school's out and the week before finals, you could get them all in and put them in the weight room and show them the PowerPoint presentation and do it 8 months after football's over. And you could do that with any sport. There's no time frame written in the CC&R about when that's to be done, and I've been working hard to get that changed. And right now it's just like we've got it as a local rule in our school district that you have to do it before the season starts. But UIL doesn't have that written down. And why? Can't know. Okay, remember this came in a couple years ago, 90-minute total contact for football. And as we all know, no one has 90 minutes of contact during a week of football practice, I don't think. If they do, you're having one hell of a football practice. But, you know, because there's a lot of standing around. And, you know, we made that change about what counts and what doesn't. And that's still in effect. We didn't change that back. But, again, you know, we make rules, and rules are meant to be what? Broken. It happens all the time. That's why we make rules, because people break the rules and we have to amend them, because we had a coach in South Texas. I'm not going to tell you what town it was, but they like practiced for 6 hours with no water breaks and and all that. And you get reports on that, and that's why we change things. Anyway, this is, you know, remember the rules. You can have 3 hours of practice. Got to be a minimal 2-hour break between a practice if you're having 2 days. Can't be more than 5 hours in a day. And now, water breaks count as practice time, whereas before you could theoretically have 5 hours of practice time scheduled in a day, 2 hours in between, but you could have scheduled 8 10-minute water breaks during that 5 hours of practice and add 80 minutes to the time they're exposed to the heat and the sun outside, and that's why that was changed, just in case you didn't know that. And then These are, again, showing you the different kinds of, that's Arkansas, Oklahoma, us, NATA, NCAA, what they recommend as far as that goes. I'm not going to elaborate on that too much. Okay, you know, Spanky was talking about the UT concussion injury reporting thing, and if that's just for concussions. There's still discussion at the UIL to come up with a new system to report injuries. And as I'm sure a lot of y'all know, if your school is the district chair during football, you're required to submit a weekly injury report to the UIL, correct? And then if you get in the playoffs, you got some more week. Well, they're trying to work on something that's smarter and easier. And I'm preaching about it being user-friendly because Spanky elaborated a while ago. He said it takes about 8 to 10 minutes to do that concussion thing. Well, 8 to 10 minutes sometime during the middle of a football season, that's a lot of dadgum time to put in something that, you know, I said I got into an argument with those people about all the information they wanted. And one of them was one of the big ones I got onto, and y'all may think I'm crazy for this. This is just my opinion, and y'all know I don't have a problem giving my opinion. Is that I don't care what ethnicity you are. Your brain inside your head's the same whether you're an Asian, a Pacific. I mean, I don't care where you came from and what you are. I just want to know how many there was and how long it took to recover and get back to return to play, and that's all I care about. And your age. But anyway, I go through and look and compare year to year to year and changed it. And pretty much the number 1, 2, 3, 4, 5, 6, 7, the incidences of injuries to body parts pretty much has remained the same year in and year out. And I went through 8 years of data that I have from all the years I've been doing this and looked at that. It hardly changes, y'all. And this is, of course, this is just football. I've been trying to get them to add soccer because I think adding soccer to this, and I know it's a little extra work, to have some more data on a different sport would be good, but they don't listen to me. Here's the percentages of injuries that occurred in game that went to hospital. And if you notice, they're relatively the same except for the ones that required a hospital visit. And surgeries went down this year and that doesn't mean that actually went down, y'all. I'm just telling you that's what was reported to us by the injury reporting system. This data is not 100% reliable. It's more informative. Okay, and from the classes of schools that reported 1A through 6A, those are the number of schools that reported the injuries that we had. And here is, for the last 5 years, 6 years, more concussions were reported this year than by increase of 3% than, or 4%, whatever it is, yeah, than before. And we think I really don't think there's been more concussions than there ever was, but the more being reported because of the law and the way that we handle them now. And, you know, we're more conservative. And I don't know about y'all. I'd like to visit with y'all sometime, but I've had more concussions at the junior highs than I have had at the high schools. And they take like 3 times longer to heal than the high school kids. Okay, cheerleaders. You know, Spanky talked about that a minute ago too, but you know, that cheerleading competition thing started this year. And I don't know how many of y'all had to deal with it or not, but it was not an issue. It's not going to be an issue, but they still have to do the concussion training and all that like everybody else does. Okay. The cardiac awareness form, Dr. Fenrick added some language, and I think y'all are going to hate this, but it still could be subject to change in the next 6 weeks because some of the literature that he's looking at. But again, if you've already done your forms and it's already signed, you just go with what you got, and next year you print out the new form. You don't have to worry about it. That's my take-home message on the form thing, because you know, one year we changed the forms in the middle of July, and they had to put me in a armored car because everybody thought it was my fault and I was going to get killed. I mean, I needed chicken wire in front of the stage. It was terrible. And I didn't have anything to do with it. But anyway, let me look. Nope. Let me go back. At Medical Advisory Committee meeting in April, a man came, and he's with the Cypress ECG project, and I know y'all are familiar with him. They go to a lot of schools and do ECGs for $15 or EKGs for $15 or whatever. And this topic is going to continue to be the hottest thing going. When legislature starts up in January, this fall, there's going to be more legislation introduced to mandate that we do this. And the push is getting a little stronger every year. That little train hadn't made it up the hill yet, but they're adding more push cars on the back of it. And one of these days, I foresee it happening, but I don't know. But anyway, what he wanted to do was he wanted to add a question. He proposed to add a question to number 4 at the bottom, that if you answered yes to any of these questions, it was mandatory that you go see a doctor and have an ECG or an EKG or an echo or whatever they required. And we turned him down and refused his proposal again because the doctor or the person performing that physical exam has the authority to require that if they think it needs to be done. And we didn't want to put anything else in writing. So you won't see that question on the form. Okay, here's the new topic, baseball pitching restrictions. This is what we have right now. It's by innings, okay? Well, last year, the UIL charged the Medical Advisory Committee to research pitching regulations throughout the country, and they wanted us, basically requiring us to change from innings to pitch count. Well, that new person that we put on the committee last year, Valerie, she's like an expert in the shoulder. She did a lot of work at Ben Hogan when she was right out of college. She went to UTA. And I charged her with coming up with a plan, and then I was collaborating with her, and Dr. Tanamachi from Mesquite was the other person on this committee that we did that, and we also collaborated with Rex Sanders, who's the head of the Texas High School Baseball Coaches Association. He's their executive director. And the Baseball Coaches Association invited Valerie and I to come to their annual meeting in January and have a panel discussion about pitch counts and do all this. Well, I had already had a previous commitment. I did not go, but Valerie went and represented us with the Baseball Coaches Association because they wanted our opinions. And she started coming up with a plan. Well, I don't have it's about a 3-page thing. I didn't put it all on here, but what I did was, this is what we're looking at right now. And the Coaches Association people that were there, they agreed with this. They're not happy, but they agreed with it for the time being. And the hardest part about doing this pitch count thing is going to be how to monitor it, how to report it if you violate the rule, and that we have a form made that the coaches have to fill out after every game, and innings pitched and number of pitches they pitch. But I didn't put all that on here yet because it's not a rule yet. This year it is a recommendation that they may do this. We thought Tuesday was Legislative Council meeting in Austin. And if y'all aren't familiar with the Legislative Council meeting, that's when the superintendents that are the voting members of the UIL meet, and they meet twice a year in Austin. And they have subcommittees like for music, academics, athletics, and those kind of things. Well, this pitch count thing, when I left the UIL meeting in April, we were all under the impression from our committee that this was going to be proposed to the athletic council this last Tuesday to become a recommendation for the 16-17 school year. And then if we needed to make a change somehow or another, that if the coaches didn't like it, we could make a change and then make it a rule by 17 and 18. Well, it didn't even get on the agenda on Tuesday. And my baseball coach, who was on the Baseball Coach Association committee, he called me and wanted to know what the hell. I go, well, I wasn't there. I don't know. I haven't got the update yet. So I called and talked to UIL on Thursday. And I like to have UILs like on speed dial on my telephone because I talk to somebody down there very frequently. And they didn't put it on there, but it is supposed to be on the agenda at the October Legislative Council meeting to be recommended as a guideline for next year. And then if it has to be tweaked and they don't like it, we can do that. And there's 1,000. The 5 and 6A schools are okay with it, but it's the 1 and 2 and 3A schools that are doing all the bitching because they only have one pitcher. It's kind of like when you have a good softball team, a lot of softball teams only have one pitcher, and that little girl throws 3 games in a row in a 3-game series sometimes. I mean, I witnessed it when Carlton's people beat me in Friendship. That little girl's arm was about to fall off her shoulder. Am I right or wrong? Yes. And but the pitch count thing, we're looking at it, and like I said, there's lots of questions because, well, okay, if they get their 110 pitches, you pull them out of the game, can they go back in and play third base, or can they bat? And the answer is yes. That's the way it's written right now. And so, but the small schools are griping. So I anticipate all this to change at some point in time in the next year. But it is a very hot topic in baseball coaching world right now in high school in Texas. And go ask your coaches what they think about it and let me know, because there's a lot of opinions, but the little schools are not happy with it. And then the other question I get asked a lot is, are they going to do a pitch count for softball? That's a negative. That'll probably never happen because it's just a whole total different ball. I mean, it's a whole total mechanism of injury is totally different. Okay, anyway, thanks for coming. If you have any questions, I'm here, and that's not me. I just had to throw that in. That's my son who just graduated from Midland High, and I just had to throw that up there.